Hi there, my name is Leah Burkholder. I'm the inpatient speech-language pathologist here at Emerson Hospital, and I'd like to talk to you about dysphagia, which is the term used for any swallowing disorder, specifically in the setting of stroke as we celebrate stroke awareness, but dysphagia is also prevalent in many other disorders. Swallowing seems simple, something that we can easily take for granted, but it's actually a complex muscular process in which food, drink, or saliva goes through the mouth, the throat, and the esophagus into the stomach. When I think about swallowing, I think about four main components. So the oral phase of the swallow, the lips, the teeth, the tongue, everything that controls a bolus in your mouth. And then the pharyngeal phase, as you swallow, the muscles in your throat squeeze to send the bolus down towards the esophagus. And in the esophagus, you have muscular peristalsis, the squeezing action that sends the bolus into the stomach. The fourth, more informal part of the swallow is, of course, the mentation. Is your patient cognitively awake, alert, and able to participate in the feeding and swallowing process? When I think about dysphagia, I think about two main concerns. One is aspiration, so the risk that food, liquid, or saliva goes down the wrong tube into the trachea and then the lungs, which may cause respiratory compromise or pneumonia. Or malnutrition. Is your patient able to eat and drink enough in order to have adequate nutrition and hydration? I'll share a few aspiration statistics with you from the American Speech Language Hearing Association. Aspiration affects 22% of adults over 50 years of age, affects 30% of our inpatient elderly population. Approximately 1/3 of patients with dysphagia develop a pneumonia, and 60,000 individuals die each year from such complications. So who's at risk for aspiration? Of course, our stroke population, but also folks with dementia, neuromuscular disease such as ALS or Parkinson's disease, and folks with head and neck cancer, especially those who have had radiation or resection to their neck. So let's talk about the aspiration risk factors that you can look out for in your patients. The quintessential sign of a stroke is often the facial paresis. So maybe you notice that there's a facial droop on one side of the face, or maybe a generalized weakness to the facial muscles, resulting in an open mouth posture. You may also ask your patient to protrude their tongue, and if it deviates to one side of the body or the other, that's indicative of a one-sided weakness. Dysarthria, so looking out for your patients to see if there's slurred speech pattern. Even if there's no overt oral motor weakness, dysarthria may be indicative of an underlying oral motor weakness or damage to the motor cortex resulting in the slurred speech pattern. Alertness. Many of our patients find themselves to have reduced alertness or ability to participate in our evaluations. Or they may be neglecting one side of their body or the other. So when they're eating or drinking, they may be pocketing food in one side of their mouth, placing them at a higher risk to choke. So I encourage you to look into their mouth after a meal and make sure that they've cleared their mouth appropriately. Mentation. Maybe after a stroke, your patient is confused or impulsive. Or they may be experiencing aphasia. Aphasia is the language disorder versus dysphagia, which is swallowing. Generally speaking, depending on where the infarct is in the brain, you may see an expressive aphasia or receptive aphasia. Expressive is when your patients have difficulty getting the words out. They're groping to find the right words, but they likely understand what you're telling them. Versus receptive aphasia, where they may sound grossly fluent, albeit a little bit confused, but the difficulty lies in them understanding what you are saying to them. So please be aware of these language communication disorders. Speak slowly and use visual aids to aid in their comprehension of what you're asking them to do. Secretion management. You may notice in your stroke patients that they're drooling out of the weak side of their lips or mouth. Or they may have a wet, gurgly vocal quality because they're not able to cough and clear their secretions independently. Or vice versa, they may be experiencing xerostomia or significant dry mouth, and it's really important to help your patients have good oral care. Respiratory status is so closely linked with swallowing. As we swallow normally, we cease to breathe just momentarily. That allows us to protect our airway so that the food and the drink go down the right tube and not the wrong tube. So if your patient is having difficulty breathing or requiring a lot of supplemental oxygen to maintain their oxygen, then they may be at risk for aspiration. Also consider whether your patients have a premorbid dysphagia, or maybe they had a special diet, thickened liquid, or softened foods before they came into the hospital. Also consider whether they have the presence of an NG tube or a tracheostomy, because these also impede the structures of the swallow. So what do you do if your patient is coming into the hospital with the possibility of a stroke, or maybe they're exhibiting some of these aspiration risk factors? I encourage you to administer the 3-ounce water swallow protocol. Emerson has this reference sheet for you in your unit, so I encourage you to ask your supervisor for this sheet, and it will walk you through each step of the way, and I'll go through it right now. The 3-ounce water swallow challenge is a widely used clinical screening tool to determine the risk of aspiration, especially in our stroke population. It's reliable and validated, and it's quick and easy to administer. It's a good predictor of your patient's ability to tolerate thin liquids. So how do you do it? First, you do your chart review and assess any history of dysphagia or risk factors that the patient came to the hospital with. Then you do your clinical observations. Look at their facial symmetry. Make sure that their mentation is good and that they're following commands. Ask them to stick out their tongue and assess for that lateral deviation. If you have any concerns at this point based on their history or your clinical observations, you may stop right then and ask for a formal swallow evaluation. But if you have no concerns, then you administer the 3 ounces of water. We use these plastic cups here in the hospital. 3 ounces of water is about halfway up. Hand your patient the glass of water, use a cup, not a straw, and ask them to drink this in the entirety sequentially. I'll do it now. And now we wait. What does a pass look like? After that swallow and within that minute following, the patient demonstrates no signs and symptoms of distress. At that point, you may consider initiating a diet for them and consider if they need a softened diet, maybe because of dentition, or maybe they need feeding assistance. What does a fail look like of the swallow screener? Well, you'll notice coughing or choking, maybe watery eyes, or when they talk to you, you'll hear a wet, gurgly vocal quality. Maybe you see them have an increased work of breathing, or maybe their oxygen saturation declines. If you see any of these signs happening, then it's fair to assume the possibility of airway compromise, and at that point, I recommend that you keep the patient NPO and request a formal swallow evaluation. While I have your attention, I'd like to just review a few other dysphagia considerations. Oftentimes, you'll notice that the speech-language pathologist recommends a thickened liquid for a patient who's at risk for aspiration. What is the rationale behind the thickened liquid? Thickened liquids move more slowly through the mouth and the throat, allowing more time for the body to process the swallow. So a thicker, more viscous bolus is less likely to drop into the wrong tube where it's not supposed to go, compared to a thin liquid that moves more quickly. So imagine this. Imagine taking a drink of thin water, holding it in your mouth and trying to talk. More likely than not, that water is going to spew everywhere because it moves quickly and it's difficult to control. Now imagine taking a drink of something thicker like a smoothie or a milkshake. It's possible that you're able to pocket that liquid in your cheek and control it while you talk. Silent aspiration. Oftentimes, when something goes down the wrong tube, our natural, most protective mechanism is that cough response. But for many of our patients, specifically our stroke patients and folks with decreased awareness or sensation, they may be aspirating and not feeling it, not showing any signs or symptoms of distress. Per Ramsey et al. In 2005, 2 to 25% of our stroke patients experience silent aspiration. And how do we know this? We use a modified barium swallow study to watch the patient under x-ray, and we can observe as penetration or aspiration into the airway occurs and there's no patient reaction. Just a quick side note about a modified barium swallow study versus a barium swallow study. A modified barium swallow study is with a speech pathologist down in radiology, and it looks at the top half of the swallowing, from the mouth to the throat to the upper part of the esophagus. Whereas a barium swallow is really looking at the esophagus and how liquid is transitioning down into the stomach. Your patients do not need to be NPO to be a part of a modified barium swallow study. Fraser-free water protocol. You may have seen this written on your patient's whiteboard. The Fraser-free water protocol is a protocol that allows patients who are requiring thickened liquids because of a risk of aspiration. It allows them thin, regular water, only between meals, in small amounts, following mouth care. Mouth care is really important here. The research and the rationale says, if aspirated, pure water contains less pathogenic bacteria than other fluids and can be absorbed into the body without causing infection. The Fraser-free water protocol improves hydration, compliance with thickened liquids, and a patient's quality of life. Again, it's the least likely thing to cause a pneumonia if aspirated. But a reminder is that water should never be provided with food or pills, because if the water is aspirated, we don't want it to bring down food or pills with it. In regard to medication administration, if you have a patient that's requiring thickened liquids, administer those medications with that thickened liquid or in a puree, like applesauce and pudding. Again, if there's a risk of aspiration of water, we don't want it taking the pill down with it. Straws. Why do speech pathologists often say no straws? It's because straws can bring a large liquid bolus to the back of the mouth, and for someone with a difficulty swallowing, this can be problematic. We want them to take small, controlled sips. The exception is if you have patients who require feeding assistance, they have a little bit more control with a straw instead of you pouring that liquid into their mouth. In these cases, you can use a straw to help them drink, but you can pinch or pull the straw out of their mouth to control the bolus size. And then last but not least, oral care. I know that this is not most people's favorite job, but oral care is indicative of total body health. It's really important for our patients who are at risk for aspiration because they can aspirate the bacteria that's growing in their mouth. And it's really important, especially for those folks who need assistance in maintaining their oral care and brushing their teeth. I want to share some tools with you that I find helpful in my practice. We have the Yankauer suction toothbrush. This attaches to the wall suction and is really good for your patients who either need assistance with mouth care or maybe they are having difficulty managing thin liquids. So it actually sucks up the secretions as you brush their teeth. So again, hook it up to the wall suction, there's mouthwash in the packet, and you put your finger over this hole to allow for those secretions to be sucked up. In this packet, it has toothax, but it also has mouthwash debriding agent, And this is really good for patients. I know a lot of folks use the Toothettes with water, but the mouthwash is